Good morning, everyone. I'm sorry we're starting a little bit late. We were having some technical difficulties with the room like this happened. So, I apologize for that, and I apologize to anyone who is attending remotely who had no idea what was going on. So we're here today because MidState Medical Center, the applicant in this matter, is submitted a CON application. They are a 156-bed acute care community hospital located in Meriden, Connecticut. They are seeking to increase their licensed bed capacity by a total of 16 beds. In MidState's application, it represents that it is a member of Hartford Healthcare, an integrated healthcare delivery system, which has adopted an institute model to advance key service lines throughout the system. As a result, MidState asserts that substantial growth has occurred, draining inpatient resources and capacity, necessitating proposed increase of medical critical care. If approved, MidState has indicated that it anticipates that the new bed unit will open by October 2025. Anticipated capital cost for the project is estimated at $8.4 million. Turn it over to Executive Director.
Today is January 26th. It's Deidre Gifford, and I'm the Executive Director. I will be presiding over this matter today. I will bring in all motions, and I will issue a decision that
My name is Dan Chuka. I'm a staff attorney with the Office of Health Strategy, and I will be assisting and providing legal counsel to Executive Director Gifford today. This is a hybrid hearing, and by that I mean it is being held both in person and electronically via Zoom, in accordance with Section 1-225A of the Connecticut General Statutes. Any person who is participating orally via the electronic component of this meeting will make a good faith effort to state his or her name and title at the outset of each occasion. Such person participates orally during an uninterrupted dialogue with peers and questions and answers. Sign up for public comment has started and will continue until 1 p.m. If you would like to supply commentary, please sign up either in person or in the Zoom chat box. For anyone attending remotely, unless you are actively participating in the hearing, either as one of the applicant witnesses or as a member of the public providing comment at a designated time, ask that you mute the device that you are using to access the hearing and silence any additional devices that are around you. This public hearing is held pursuant to Connecticut General Statutes, Section 19A-639A, sub F, sub 2. Although this does not constitute a contested case under the UAPA, that's the Uniform Administrative Procedure Act, the manner in which OHS conducts these proceedings will be guided by the UAPA provisions and the regulations of Connecticut state agencies, 19A-9-24. I generally will not be asking questions of the witnesses, but Dr. Gifford will. In addition, Office of Health Strategy staff is here to gather facts related to this application and be asking the applicant witnesses questions. This time, I'm going to ask each staff person assisting with questions today to identify themselves with their name, of their last name, and OHS title.
Harrison, last name Harrison.
My name is Stephen Lazarus, Lazarus, I'm the CEO and supervisor.
My name is Annalise Viola, F as in Frank, AIELA, and
Also present remotely are Faye Fentis and a couple other OHS staff, as well as Maya Capozzi, who is in person with us. There are other OHS staff members that are assisting with hearing logistics, including gathering of names for public comment and providing miscellaneous other support. The certificate of need process is a regulatory process, and as such, the highest level of respect will be accorded to the applicants, members of the public, and our staff. Our priority is the integrity and transparency of this process. Accordingly, decorum must be maintained by all present during its proceedings. Hearing is being transcribed and recorded. The video will also be made available on the OHS website and its YouTube account. All documents related to this hearing that have been or will be submitted to OHS are available for review through our certificate of need portal, which is accessible on the OHS CON link. In making our decision, Executive Director Gifford will consider and make written findings in accordance with Section 19A-639A of the Connecticut Journal of Statutes. Lastly, I wish to point out that by appearing on camera in this hybrid hearing, you are consenting to being filmed. If you wish to revoke your consent, do so at this time by exiting the Zoom meeting or the hearing. So we're going to start by going over the exhibits and the items that we plan to take administrative notice of. Then I will ask if there are any objections to those items. The CON portal contains the amended pre-hearing table of record in this case, which was filed yesterday. Time of its filing, exhibits were identified in the table from A to Q. Mr. Lazarus, Ms. Biella, and Ms. Harrison, do you have any additional exhibits that you wish to enter into the record at this time? You. So in addition to exhibits A to Q, you are hereby noticed that we are taking administrative notice of the following. The statewide healthcare facilities and services plan and its supplements, facilities and services inventory, the OHS acute care bill discharge database, all payer claims database, claims data, hospital reporting system, HRS, financial and utilization data, and the hospital's community health needs assessments. We're also taking administrative notice of the following CON dockets, which were referenced in one of the applicant's filings. Docket number 20-32392-COM, which encompassed Health Rehabilitation Hospital of Greenberry, sought to establish a 40-bed chronic disease hospital providing inpatient physical rehabilitation care. Docket number 22-32533-COM, in which Connecticut Children's Medical Center sought to increase its licensed bed capacity for medical and psychiatric inpatient unit. Docket number 22-32554-COM, in which Connecticut Children's sought to increase its licensed bed capacity for purposes of expanding NICU services. As the hearing progresses, we may also take administrative notice of other matters, including prior OHS decisions, agreed settlements, and determinations that may be relevant to this matter, but which have not been yet identified. So, counsel for the applicant, the medical center, can you please identify yourself for the record?
I'm Jennifer Fusco.
I know that we are awfully close. I want to make sure that you speak up for the benefit of, excuse me. And that goes for everyone else who is in attendance today. Are there any, Attorney Fusco, do you have any objections to the exhibits in the table of record?
I do have some questions. There should have been support yesterday. So I didn't know if other public comment had come in as well, but I know it's in the section for public comment. We can upload that to the portal as well if that makes it easier, but if that could be added to the record.
To my knowledge, we haven't done that.
We can verify who he emailed it to, and we can also upload it directly to the portal. That's easy.
Yeah, if you can upload it, that would be great. We don't have, we haven't received any other public comment to my knowledge, which is why there's no other file on it at this point.
I also did I do have one objection, but on the passage, and notice of a number of OHS databases. If there is particular information you intend to put in the databases, the applicant would ask for notice and respond in the final decision. And we do have an objection hospitals, Middlesex and HHCC. That came to us through the completeness letter with just an indication that we could comment on it. We reviewed it. It doesn't have any sourcing. We're not sure who prepared it. It doesn't have any sourcing, so we can't validate the data. But it does include 4 tabs, and we look specifically at MidState information. Can't provide any comments on the populations with respect to New Haven or Middlesex because they're not HHC system hospitals. And I think as we've made clear in our submissions, we believe the population of Fedman is more complicated than what that methodology suggests. And we wouldn't be privy to any information to be able to comment on their actual utilization and capacity. And I guess we would raise the same issues with respect to HHC, with respect to the flaws in the model. So for that reason, I would object to its inclusion record and its use in any decision making in this matter.
We're going to reserve for now.
And-
We'll get you an order on that.
Absolutely, and I will add, I will say that we object to it absent further clarity on its intended use and ability to respond. I mean, it wasn't clear what you were looking for from us and whether we could provide what you're looking for, but in the vacuum, we would object to it being there.
Ask OHS staff, do you anticipate asking questions about it shouldn't present an immediate issue?
And to the extent that there are questions, I'll just section for the record and we can questions as best we can. Other than that, no objections.
Okay.
Sorry.
So we'll render an order on that after we have an opportunity to speak. For the time being, though, all other exhibits will be entered as full exhibits. Did you have any objections to the administratively noticed basis or its themselves?
No objection to the databases or the dockets with the caveat that if there's particular information you intend to use, you would like the notice and an opportunity to respond.
With that, Fosco, did you have any additional exhibits that you wish to enter at this time? And the public comment issue.
Yes, I'm not sure.
So we will proceed in the order established in the agenda for today's hearing. I would like to advise the applicant that we may ask questions related to your application that you feel you have already addressed. We will do this for the purpose of ensuring that the public has knowledge about your proposal and for the purpose of clarification. To reassure you that we have reviewed the docket, I will do so again before issuing a decision. Dr. Gifford, more importantly, Dr. Gifford will before she renders her decision. Excuse me. Using an old script, I apologize. As this hearing is being held in hybrid fashion, we ask that all participants attending via remote Zoom enable the use of video cameras when testifying or commenting remotely during meetings. All participants and the public shall mute their devices and should disable their cameras when we go off. Take a break. Please be advised that although we will try to shut off the hearing during the breaks, it may continue if the recording is on. Any audio or visual has not been disabled will be accessible to all participants. Public comment taken during the hearing will likely go in the order established by OHS during the registration process. However, we may allow public officials to testify out of order. We will call each individual by name. It is his or her turn to speak. As I mentioned, registration for public comment has already begun. And it is scheduled to start at 1 p.m. If the technical portion of this hearing has not been completed by 1 p.m., public comment will be postponed until the technical portion is complete. In addition, if we end early, we still cannot start public comment until 1. We carve out the time, that way people who are on lunch break or set aside the time are able to participate. The applicant's witnesses must be available after public comment. OHS may have additional follow-up questions based on the public comment. Are there any other housekeeping matters or procedural issues that you would like to address before we start?
With respect to the availability of witnesses, do you say here, or through public comment, or could they return remotely? What timing?
We're okay with joining remote.
And we do have, I think, I mentioned this to you in a phone call, we do in addition to our form, since Edwards is here to answer questions. You said that you have a question that would be better answered by her than one of the pre-filed witnesses. She's available for questions.
So Attorney Fusco, would you like to make an opening statement?
Good morning again, Dr. Gifford, Attorney Chuka, and members of the OHS staff. Again, my name is Jennifer Fusco, and I represent MidState Medical Center. Thank you for this opportunity to make a very brief opening remarks today. Since before you requested at 6 when application is not just about demand, capacity, and access. It's about quality and safety. A hospital or the health system that is striving to provide the best in care while also bringing value to their health. It's about ensuring that all patients have access to the highest quality care in the most appropriate settings without undue delay that can have adverse consequences and drive up healthcare costs. It's the office proposal health strategy with this acceptance. Today we brought this to you because I've done 3 physicians with us. We're going to be hearing from Dr. Clark, Administration Officer for HHC, share with you HHC strategy to transform the delivery of healthcare. Discuss how the transformation of the estimation for complex and for specialized services embodies the system's excellence, access, authority, and equity. As a result of this transformation at MidState, demand for inpatient services at the hospital, additional beds are needed to continue to provide timely quality care. You're going to hear from Dr. Justin Wilson, and he's the Vice President of Medical Affairs for HHC Central Region, and he is the former chair of the emergency department at the hospital in Connecticut. Dr. Finkelstein is going to share with you MidState's quality and safety journey, how the hospital is community excellence, a destination for We'll also tell you about how the enhancements and services that MidState and its reputation for quality to disclose and for inpatient services that have in the hospital available capacity.
Fusco, I'm sorry to interrupt, but people online are saying they're having trouble hearing you.
Okay.
What that is.
Okay.
And,
I can try to speak louder, but Dr. Finkelstein will also testify about the efforts MidState is taking and optimize its inpatient bed capacity, and why the addition of licensed beds is a viable solution to the capacity issues facing the hospital. And finally, you'll hear from Dr. Dan Engelberg, Director of Emergency Medicine at MidState. He'll testify about the practice of e-boarding, which involves holding hallways and other areas while they're waiting in inpatient bed. E-boarding can cause issues, not just for admitted patients, but also for patients waiting. Reverend Engelberg also discussed the efforts MidState made for admissions and overcrowding. The addition of 16 inpatient beds will result in progress for reducing flow and enhancing the quality of care for patients. As I mentioned before, we also have with us today Jeanette Edwards, who's the VP of Operations for HHC Central Region. Ms. Edwards was involved in preparing the technique model for the state application, and she's available to answer questions regarding that model and hospital operations generally. The evidence that's been presented in this matter up to this point and what you've been today will show that there is a clear capacity at MidState. Only way to address this need, future access, timely access to services at the hospital is to approve this request for licensed beds. Constrained capacity at MidState is a very real problem that can have real consequences. And approving this application will provide much to provide high quality, safe care to patients.
So before you do that, I'm just going to swear all of your witnesses in. So, Attorney Fosco, you've already identified them by name and title. So, there's four of you, right? The four of you, please raise your right hand. You solemnly swear or solemnly and sincerely affirm, as the case may be, that the evidence you provided in your pre-file and the evidence that you shall give or have already given in this case shall be the truth, the whole truth, and nothing but the truth, so help you God or upon penalty of perjury. So for the witnesses, when giving your testimony, please make sure that you state your name and adopt your written testimony. Again, please try to speak up. So, Dr. Sorry.
It's all right.
You can continue.
Thank you. Morning, Gifford. Staff. I'm Dr. James Carden, Chief Immigration Officer for Harvard Healthcare. We really appreciate the opportunity to share our Harvard Healthcare strategy and inform the delivery, specifically as it relates to these additional beds. Our path to transformation ensure there's timely access to consistent, excellent care, affordable. This enables MidState and Hartford Healthcare to make meaningful space reimbursement. The time goal. MidState is really an excellent demonstration of the purposeful transformation we can do. Historically, well, community hospital more complex hospital should be utilized and transform into a center of excellence, allowing us to provide care. Additionally, procure this includes oncology care, vascular care, and evaluations for comprehensive vascular surgery. I'm in the local community, want to receive care and in order to ensure that we continued our efforts around affordability, it is important to insight on a total cost of care and maximize MidState's capacity to provide higher level. It's imperative that we also develop and deploy ambulatory sites of care, allow us to provide appropriate services in lower cost settings at a lower cost. Ambulatory sites that not only afford us capacity, procedures, but also a much better patient experience. What I'd like to do is spend a little bit of time around each of the four components. Some sense of the progress that we've made. First, excellence is really foundational to our transformation. We are committed to measuring, managing our quality, and then seeking and looking for external validation of our performance in order to determine that. And that starts with our lead population. We're very proud of the designation we've received. Our care system now got paid ratings across every facility. Conventional measures of quality and safety. Only 3 other systems of our size that receive B ratings across all the hospitals, and only 30% of hospitals in the nation receive as across all ranges of services. Secondly, CMS star rating. MidState has a 5-star rating. 2 hospitals in the state that carry that rating. Again, broad measures of quality and safety. Thirdly, hospitals are hospital acquired conditions. These are things that happen in the hospital. Reduction of we have for the last 2 years been able to get any whatsoever from CMS that are on the threshold. All those penalties given proven. Patient experience is 4 stars out of 5. It's above the state average, it's above the national average. Orthopedics, one of our focused areas of development, has had 5-star performance on hip, knees, and spine surgery. National Association of Nursing Excellence Award was attributed to MidState. We have advanced certification in spine surgery, the first program to receive that, as well as hip, knee, and shoulder surgery. All of that is the foundation, which is why we're confident the care we're delivering in that environment is not only more specialized, more advanced, but at a world-class level. Timely access to care becomes the critical measure. It's not good enough to just have a small place to do care. We want to make sure it's broadly available. Trying to improve that access. About the orthopedic center, spine, vascular, cardiovascular surgery. Very importantly, as we've developed those kind of capabilities, we've increased the complexity of care we're taking care of. These mix index, the measure of that complexity, 1% between 2016. In addition, the ambulatory environment is critical. We talk about building on access. It's not just their hospital, but the ambulatory environment as well. And those ambulatory environment allows us an opportunity to deliver that care at low cost. Development of our ambulatory surgery centers, care centers, this is effective coordination of primary care so that we can improve the access, which is all of that allows us to have affordable sites of care. New example. Cases, yes, increased significantly in the hospital setting. 1,600 cases in 2017, 5,200. But it's important that those cases move from typical inpatient. 20% were done in an HOPD setting. That were done in 80% of them are done in out of the acute care facility in HOPD early. 1,600 cases done in 2021, and 9,400 cases done in ambulatory surgery centers, not at hospital rates. Recently had 3 general surgeons move their cases to the PSC, which is a further development of the capabilities we can do in surgery centers. These were all done for appropriate patients. Act identical kind of outcomes and quality that receiving much lower cost and GI procedures typically done in an inpatient or outpatient hospital outpatient department. At 66%, 15,700, 26,000 of those procedures being done in care strategy. Attempt to reduce the low level visits for patients who can care more effectively, where we have increased from 25,000 visits to 79,000 visits, a 205% increase between 2018 and 2023. In addition, we have seen the impact on each level of care. This has increased by 18% over that time. 20% of total visits having been one level 2 historically, now down to 15.7%. That impact is having the effect we want, which is low level institute. These are all in addition to the measures that we are singularly focused on in terms of reducing inpatient admissions, in admissions, length of stay, reducing our complications is both cost effective and reducing hospital required preventive care that we have in diabetes management. When we look at those, not only by the broad who are primary care subsegment that by at-risk communities, same care, challenge communities we do in the general population. And that has been a year-over-year measure of improvement. We're seeing control of blood pressure for our patients. 75% of them are at goal. 110,000 folks that we're responsible for hypertension across the system, and over 88% of their diabetes effectively managed with an A1C. Still see some disparity between the at-risk communities and not. In the focused effort to figure out what are those barriers to make sure that care is equivalent across all of our. All efforts to us to ultimately decrease the chronic conditions and all causing people. Equity is a core value for us at Hartford Healthcare. The center of equity system, and it's important to ensure that we include the lens of diversity into that. It makes it better, it makes it more relevant, it makes it more successful at delivery. We have specifically in MidState racial justice with champions. This is a partnership and the facility to ensure that they have a voice at the table, certainly recognizing that often have shown up in the past saying, well, we're here, we know what we have to become more sensitive to listening to what we need. How do we adapt and we are because there are challenges that we have power resource group, chance program, singularly focused on ensuring capturing accuracy language data as well as social determinants, deploying our neighborhood health team based services and social services in access for several perspectives across area. Lastly, the payment model is critical for us to continue to move this progress forward. We have to move to a service model in risk-based payments. That wholeheartedly with that give full risk for 55,000 folks who have Medicare Advantage. Joint venture Medicare plan and 8,000 members. 65,000 or so patients. Well on quality. Affordability becomes key in making sure that all of the efforts in this system of care allows us to have an opportunity to execute and perform well across many of the patients. Lastly, I just want to highlight that we also participated in year 6 of a corporate plan. The efforts that we did in alternative models, CMS program, and the kind of intentionality and the dramatic results you can see with this and how aligned partners. Look at the quality of that program. 6. Initial score joined that program. 4.4 out of 20. Recent results were 8. The inflation rate was 1.4%. It's now 0. Decreased by 10%. PIP utilization went from 87% to 5.3%. Home care, 89%, 26, 28%. Inpatient length of stay dropped from 2 days to 1. Inpatient to outpatient, it's not the ASC, it's not measured in the program, it's moving from 5% to 77. All of those things are demonstrating better quality, lower patient, lower cost of care. So all this result has resulted in being recognized as a destination for patients to receive. It's further. It's important to understand we've exceeded our space capacity to provide the care that patients in our community expect.
If I may, before we move on, I think people will still be having trouble hearing us. So
I
it
was
wasn't
gonna
me because
interrupt.
he speaks louder. Is there a better way to capture our voices?
My understanding is that there are microphones in that cabinet.
there's public comment. We need it. Figure out how we can do it. I'm great, I have to go.
Are you okay with taking a break?
Absolutely. I just
Okay.
want to make sure everyone can hear, so.
Okay. We're going to, what is hopefully a brief break, try to resolve the audio issues. Again, your camera, be aware that the